Good morning and welcome to our monthly live broadcast from endovascular cases from Mount Sinai Hospital here in New York City. I welcome you, one of the moderators, Vishal Kapoor, joined by my colleague, Dr. Raman Sharma.
Good morning.
So now we present our last case of this year, ending on a high note with a very complex, interesting case by Dr. Krishnan and Dr. Guja here in the lab. So without further ado, good morning, PK. Good morning, Karthik.
Hey, good morning, guys.
Good morning, guys.
Morning. So good morning, everyone. Good morning, Raman. Good morning, Vishal.
Oh, and just to add on, we have Dr. Song remotely joining us as well, who will also be answering our online question and queries if you have, and as well afterwards. So, morning, David. We can't hear David.
Okay, we can't hear David, but he's there.
Yeah. He's
so,
there.
Good morning, everybody. Good morning.
Good morning. There you are. So yeah, the virtual moderation has become a big hit. We've been getting a lot of questions. I think this is something that's going to work really well. But anyway, welcome everyone. And so we've got our team here together. We've got a really, really tough case. And I think it'll be fun to talk about how we deal with these kind of difficult SFAs. So as everyone knows, we have Dr. Guja here, who's our, I can't quite say, there you go, pulled it back, who's our director of Mount Sinai South Nassau and always part of our team. We got Ray Lascano, who's our interventional nurse practitioner.
Yes.
We have our nurses, Rekha and Kimberly. Sorry about that. Did I say it right or no? Okay. and then we have Awad, our fellow, who's also here, and of course Damien and Ramon, who are outside. So we got a really, really tough case, and we're probably going to need the whole hour to do this. So we want to go ahead and why is it not going up and over?
Probably not having this.
So we got a really tough case. So we're going to go ahead and have Dr. Awad go ahead and talk to you guys about this as we do it. Hold on.
It looks like you guys already at 8 a.m. have the Outback open. Is that correct?
Yeah.
It's a B-back,
Be-back.
Okay.
All right, Awad, if you want to start with the case presentation, and then we'll switch to the angels.
It's the Christmas special is what it looks like.
You want to try the overnight, PK?
No.
All right.
Yeah, get an 018 wire then.
Give me an overnight.
Okay, go ahead, Awad.
All right, good morning. So I'm going to introduce the patient. So we have a 63-year-old gentleman with bilateral lower extremity claudication, left greater than right, despite maximal conservative therapy. He did undergo a 12-week exercise program, but has persistent left lower extremity claudication. He was not a candidate for cilostazol due to heart failure. So as far as past medical history, he has hypertension, heart failure with reduced ejection fraction, 30 to 35%. He has end-stage renal disease on hemodialysis. He also has a history of NSTEMI. Back in June of this year, he had PCI of the RCA. And then in October, he had PCI of the LAD. He also has diabetes, and he also has a remote history of a brain aneurysm. Social history, no tobacco, alcohol, or other drug use. Medications, patient is taking aspirin, clopidogrel, rosuvastatin, Entresto, and hydralazine. So imaging-wise, patient had an echo. His EF was 35%. He previously had an ABI, which was significant bilaterally. He had an ultrasound which showed severe bilateral SFA disease. And then he had a diagnostic angiogram a few weeks ago that showed bilateral SFA CTO and bilateral severe popliteal disease. And this is the image of the left. So you can see he has a very severely, heavily calcified CTO in the left SFA that reconstitutes in the distal SFA. He has severe popliteal disease as well, and he has 3-vessel runoff. We'll just let this play.
Oh, why? You had said this guy is not a smoker, but was he ever a smoker?
No.
Well, it's more of a dialysis patient presentation.
Yeah.
Numbing medicine.
Dialysis.
Numbing.
So Dr. Krishnan, do you want me to go through these or
well, you can stop there for a second.
Okay,
So Raman, Vishal, as you can see, we're already struggling here. It's a very, very difficult case, and let me show you our images. Okay. So let me go back here. It's a extremely calcified case. Okay, so we'll just start here. So the iliacs are not fun. You can see very calcified, tortuous, not fun. So then we've got this horrible SFA calcium. Reconstitute at the level of 25, and then we went down to 3-vessel runoff. So the options Karthik and I spoke about, give me some numbing medicine. Options Karthik and I spoke about is how are we going to cross this? So we got a distal pop lesion. So we have to deal with that at some point. We've got to get through the proximal SFA. But with this amount of calcium, the options are two. One is obviously we need to cross this, and let's talk about the techniques of crossing. And the second part is obviously destination therapy. So I just want to show you how difficult this was. So we went with an 035 catheter. You can see the level of calcium that's level and fully just encased in calcium. And then we went with the wire. And Ray, how do you play this? This is an 035 wire with a stiff angle glide with obviously a what is that called? Terumo Navicross. And you can see as we're pushing, nothing, no go at all. So then we decided to go with the B-back to try to go up and over. Unfortunately, the B-back would not make the curve in the aorta. So now what we decided to do was to stick the direct SFA stick and come up with a wire and try to cross it from below and snare it from above. So we didn't want to do the pop. Can you move this? My elbow's coming. Yeah. We didn't want to do the pop because of the fact that, the pop obviously is an issue in terms of the calcium. So we're going to do the direct SFA stick right here. So the idea is first to be parallel with the SFA, and then you want to go ahead and give lots of Lido, which is what we're doing. I'm sorry, sir. And, we're going to have to give Lido anyway because of the paving crack. We're going to have to give lots of Lido. So I
think, Raman, with that degree of calcification, it's like pretty much worse than a tram track. It's like pretty much looks like a natural stent, obviously because of extensive calcification.
Careful, I got
anything else you would have done before directly going into do a direct SFA access? Any other change in wire
in there?
you would have thought about, or just like,
way
of
up
course,
top,
you go in
it doesn't
035, but you quickly switch
there's
over.
No wire from the top.
Yeah,
we don't need it because we're distal, right?
I had a case of this just like last week or 2 weeks ago, and I mean, this is like it is a total nightmare. I mean, there's so many steps at which you have to have a lot of like really serious decision making.
Now this is my Lido.
What's your access
give
side?
me a
a
needle, a straight needle.
What is the amount of wire escalation you can do from the antegrade? And then how much time do you give yourself to do the antegrade?
Right.
Do you use your and how subintimal / adventitial you're probably going to be considering how much how much calcium there is. But I would say, I mean, so the direct SFA stick I like because you do have a pretty good landing mark with the calcium.
Right.
But I think for feasibility purposes, I would probably have gone with the tibial first. Do a bareback. That's typically always my go-to.
Right.
The PT didn't seem to have any disease. So I think just going with the bareback, no sheath, just with like a CXI catheter and a V18 wire, and then do the exact same plan here, really.
So the reason we didn't go with the tibial is I don't think we have enough pushability. We're going to need a 035 system.
Also, we have only one big vessel to the foot.
And plus we only have one vessel run off to the foot with a severe popliteal stenosis that we have to deal with on the
3.
No. Meaning one.
The 80 is diseased down there. And PT peroneal is there, but PT is the main vessel going down to the foot.
Okay.
So I think we have the biggest point which Raman brought up is the pushability. I mean, the way it's so much calcified, I don't think any
overnight not going to work.
Any of the stiffer wires will really cross through. It's like pretty much like a rock. And you need more pushability.
All right, give me an overnight trailblazer.
In this case, probably closer you are, the more pushability you have. The only other thing I would probably would have tried from the top, I guess off-label is straight stiff wire, try to find a lumen. If that crowd, the worst case is back of the glide wire, try to poke that calcium chunk which is going there, and then you switch over to, of course, you switch fast.
Well, what we can do is let's go with the trailblazer, try for a little bit, and then go with the
trailblazer. 600 gram of weight essentially, so it's not like a small tip. You just have to have control because you can perf and fly off like there's no tomorrow. But that's the only other thing I think in my mind would have been there before. But I think switching over to direct SFA stick is probably the next intuitive treatment here in this case.
So Vishal Raman, we decided to go with an 018 trailblazer just to give it the college try. I personally believe that this is going to be an 035 with the sheath and the SFA in order to get through. So we're just going to go ahead, go with the 018.
So just for the audience, can you show us how high up or how far away from the popliteal you were to get that SFA stick access? I know you want to find the normal segment. Can you just describe it a little bit more?
There's no normal segment here.
we are
relatively normal.
We are probably in the adductor canal area.
No, we're below the adductor canal. We're probably in P1, segment here, and I'll show it to you in a second. We have to wet this wire down to make sure that the wire doesn't.
Is there any yeas and nays of this is the no stick zone for your direct SFA access, or you can stick anywhere?
Not really. I mean, truthfully, not really. I mean, I'm just going to give Karthik a little bit of support here. You can see this is going to be very, very difficult.
Can we see the angio as well while it's going on, please, on the side screen?
Angio on the. Oh yeah. Oh, they're not seeing the angio.
Thank you. Yeah. That's better.
Thank you. Okay. So Karthik's going to try to push, and I'm just giving pushing.
So
there.
right now you have an 018 system with an 018 wire.
There you go. Okay, keep pushing.
No.
Yeah. Just keep pushing. See what happens.
There's no
pushability
at all.
There.
Something's happening.
Keep pushing. Pull the wire back and regroup the wire. Give us another wire, guys.
What wire?
We have a V18, but we have a command here, a 18 command.
Wait, is it
yeah, it might be.
Can you advance the wire? Get us a command. Command's not going to help here.
No,
18
maybe an Astaro 30 or a 40, I might try to poke.
Astaro 40.
If you're an 018,
No, I think we got to go 35 system here.
No, I agree. But like I said, before you switch over.
I usually like to give the 018 system a little bit more of a try. Because even if you end up something like this, I mean,
hold on. That's fine.
This is still an 018
Okay, hold on. Let's get a. That's okay. We can always
from the top.
Outside.
Correct. That's expected.
You're expected to have a subintimal, submedial adventitial cross.
And
I think as long as you're within the actual vessel wall, then at least you have your options for how you're going to be crossing, as far as how you're going to be deciding on your destination therapy. And just for the record, I want to say that looked like an 018 system, which
it was an 018.
It's an 018.
They found the non-calcified, the only non-calcified segment in the vessel. They found it, which is good.
Feasible from the tibial, but okay.
That's what you're going to try. All right, so that's where the. So-called,
There's a question from the chat. Given this type of lesion, calcified CTO, would javelin be in the discussion for utility here, or is the calcium burden too great?
You're good.
This is beautiful. You're in a great position here.
Yeah.
So,
1 second. Let me
javelin, yes or no? I don't think it will actually make it across the aortic bifurcation.
No, you're right on the side of the
right in the side of the
vessel. Didn't cross?
Yeah, I mean it's a good point. People have started to use javelin as a CTO device where they go bareback without the wire, try to break the calcium at the hub and try to cross over. You've been tried. The results, again, anecdotal, personal experience, me and Raman have done it. It's hit or miss. In this degree of calcification, I don't think it's really going to do much of a dent to it to really cross through it. Could you try it? Yes. But, remember, at the end of the day, it's the economics of it as well. I'm sure they're going to use shockwave or lithotripsy, I guess, in this. I'm assuming that's what their strategy might be. We can discuss about it. But in this degree of calcification, the threshold will be very low to use it.
Then we have to use our startup.
Then, in this case, you already know you're opening it. You might use the javelin and go from it. But I think not a bad thought.
Give us an 035. What does it go from below? Give us an 035 Navi cross from below. This is and give us a new.
So let me ask you this: Do you like
below.
it? So you're happy with your wire going from below?
No, yeah, I am happy, but I'm not happy because the problem is
we're going
inside the vessel.
So we're going to go with an 035 Navi cross. We're going to change out for a V18 and then go with a Navi cross from below. So I'm going to put a Navi cross and then pull out the wire. Yeah, pull out the wire. Now go with the V18. And what we're going to do is we're going to track the Navi cross into the vessel and go with an 035 wire from below. Try to loop it up to that wire. If we can't, then we're going to have to figure out maybe an Outback, maybe a facilitated re-entry, something of that sort.
Yeah, because the way it looks is, like you said, you're way deeper into the vessel wall.
Get us a 4 French dilator.
So in order for those to connect, it has to come back into the vessel, which looks very hard, purely going by a Navi cross and a wire. And I don't think they're putting a sheath in.
We have to look at our destination options and decide, if you're going to decide that, this is going to be...
leave it there. Walk it out.
This is going to be a covered stent, and we can't get away with anything else other than the covered stent.
Now give me the Navi cross.
Then I guess facilitated re-entry is the best way to go because you create your plane and everything and then do it.
Well, I mean,
Ray, I need a
to be honest, like that's what me and Raman were thinking about. In destination therapy, I don't think we have much of a conflict. It's either going to be Supera for me or covered stent.
I don't think Supera has a role yet. This has got to be crack and pave.
Well, that's something.
Supera inside a covered stent if you want.
Right.
Some people do.
I mean, that's probably what we might have to do, Raman, because I don't think even with the crack and pave, it's going to expand. It might need more support.
And you're gonna. I mean, this is like right at the middle of the screen. You're about almost 3 millimeters outside the actual tram track. So you can assume that that probably means at least 4 millimeters from the actual lumen.
Right.
I mean, so.
Or like I said, worse case, if you're really adamant, I don't want to put a long covered stent with an outflow being an issue, which I think should be good in this case. I would not be concerned about that.
Support.
And put a covered stent, or you can do a proximal, a night loss stent.
All right, get us a 4 or 5 slender.
We have it.
035 bareback. That's
have it right here.
that is really going bareback.
Yeah.
So I think we still might have to do Outback into that facilitated area.
So we're going to go with a 4 or 5 slender here from below.
I think, I mean, exactly. I was going to say, I think in this case, I would be probably a little bit more aggressive and put a real sheet down there. So in case you have to do an Outback, we can do an Outback. If you're thinking of putting a cover stent anyways, the entry of the SFA can easily be taken care of. So if you want to enter from below and back into the lumen or the other way around, or even facilitated cart, reverse cart.
Yeah, I mean, but
is another option.
I mean, they're two really, really good things here. There's a proximal landing zone and there's a distal landing zone. And where PK had access was not that far away from the reconstitution. So even if you do
it's right above it.
Yeah, so right
below. I need a dilator.
So should you choose to go covered stent, which is probably going to be the destination here, you just cover that.
I agree. That's how the whole point is.
And then you're all set. And I think this is a this is a challenging case. I mean, sometimes you get lucky, and if you go from the retrograde approach, you'll find some little tiny microchannel, and you can take some hydrophilic wire all the way up. Yeah. But I mean, this is
this is really out of the vessel technique.
This is a tough one. This is a tough one.
Okay.
So now you have a 4-5 slender.
Yeah, and I'm still not going.
Dilator is still not going.
Maybe change for a what wire do you have in the body right now?
018 V18.
V18, even that's not giving you the support, huh?
The micropuncture dilator won't help?
Yeah, give us a micropuncture dilator.
That's what we have to do next, and then change it to 035 system.
Yep.
Yeah.
Micropuncture dilator.
There you go.
Actually, just put the whole system.
Give me an 018. No. Give me the whole system. We'll change it to an 035 as soon as it goes in.
So for those at home, this is kind of the pain in the neck. So anyway, while we're doing this, I'm going to have a Wad go ahead over some of the techniques. You can put us on the, you can listen to Wad, and in the meantime, Karthik and I will struggle here.
I think you got it. Give me an
035.
035.
035 stiff glide.
Can I get the slides, please?
Guys?
Perfect. I have it here.
Slides. Is it destroyed?
Okay, so while it's getting it up, I mean, there's a couple other comments in the chat talking about DCB.
Get us another stiff glide, please. Angle glide.
It's an important concept to consider here. What is the role of DCB? And I think if you think about just what the physiology of where that drug uptake is really optimal, right? It's in the intima.
Correct.
So
what's the ACT?
We know based off our cross that very little of the intima is involved right now. We're quite far outside.
Correct.
And that's to not even discuss the risk of perforation here. So I think DCB is a great option for some SFA CTOs. This would not be one of them. That's for sure.
All right, Dr. White, let's see.
Okay. All right, so just going over the basic idea of what paving crack is. So this is just a figure adopted from a paper. So in figure C, so initially you can see when you dilate with the non-compliant balloon and you don't get good expansion, such as in figure D, then one option is to place a covered stent, such as a Viabon covered stent, which you can see in figure E. This figure was adopted from a paper from Andre Schmidt in Germany, and what he tends to do is, like we were talking before, is place the superior stent after placing the covered stent. So you can see that in figure F, the expansion wasn't great after the Viabon covered stent, and then a superior stent was placed. So basically, the idea is the PAVE is the covered stent, and then afterwards, once you have that covered stent in, it gives you some leeway to dilate with high pressure, and that's the so-called crack. And then just some data in terms of covered stents in the SFA. So the first study that I wanted to go over was 5-year outcomes of the Gore Viabon stent. This was multi-center post-marketing surveillance study, 2016 to 2017. 320 symptomatic patients with PAD and fempop lesions greater than 100 millimeters, and most of them had TAS CRD lesions. Most of them had CTO. And about 40% had moderate to severe calcification. At 5 years, the primary patency was 62%, primary assisted patency 74%, secondary patency 82%, and freedom from TLR 75%. Also, another retrospective study, this is from Dr. Schmidt's group in Germany. So what they looked retrospectively at 67 patients from 2011 to 2017 with heavily calcified lesions, and their strategy was aggressive pre-dilatation followed by the Viabon stent graft and then a superior stent inside of that. Again, most of the patients had CTO and TAS D lesions, and at 1 year the primary patency was 79%. Its secondary patency 91%, freedom from TLR 85%. So this is a so-called armadillo study. This was comparing covered stent with Viabon versus superior stent in fempop lesions. This was 2017 to 2021 in Japan. So 137 patients had received Viabon and 204 had received Supera, and what they did was then they created propensity matched groups to compare, so 150 matched patients with no significant difference in multiple baseline characteristics. The primary patency at 1 year was 81% in the covered stent group and 71% in the Supera group. This was not a significant difference, although the Viabon group had a little bit of a higher patency, and also freedom from TLR, no significant difference. So this is one of the randomized studies that we have. So this is 3-year results of Viabon stenting versus bare metal stenting in SFA disease. So 148 patients, 76 received the Viabon, and 76 received the bare metal stent, 72 received the Viabon. The moderate to severe calcification was not quite evenly balanced, so 62% in the Viabon group had moderate to severe calcification, and 42% in the bare metal stent group had moderate to severe calcification. And at 3 years, primary patency did not significantly differ, although stent fractures were much more common in the bare metal stent group, 50%, versus the Viabon group, 2%. Primary assisted patency rates were higher with bare metal stent, 88% versus Viabon, 69%, but secondary patency rates did not differ. And then finally, another randomized trial between covered stents versus bare metal stents. This was 140 patients, about half received bare metal stent, half received Viabon stenting. And they looked at intention to treat and per protocol. And in both cases, the Viabon had a better 2-year patency rate with no significant difference in TLR. I also wanted to mention the Disrupt PAD trial. So this was a study using lithotripsy. So about 306 patients, half were treated with IVL, and half were treated with PTA prior to DCB or stenting. This is more recent, to 2017 to 2020. Primary patency at 2 years was significantly higher in the IVL group, 70% versus 50% in the PTA group. Requirement for provisional stenting was lower in the IVL group, 4.6% versus 18.3% in the PTA group. There were no perforations in the IVL group, and freedom from TLR, there was no significant difference. So I wanted to quickly also mention PTAB, which can be an option in these patients, percutaneous transmural arterial bypass with the detour system. So this has been studied in patients with long fempop lesions, 20 to 46 centimeters in length. And usually this is for patients who have undergone repeat endovascular procedures. For our patient, of course, this is the first attempt. And it's usually for patients who are not good candidates for bypass. And basically the idea is if you have an SFA occlusion, you can jump into the femoral vein with the endocross device, and then you can come back into the SFA or POP, and it kind of creates a bypass. And then you have stent grafts that are placed. And as far as clinical success, that was defined as limb ischemia improvement by Rutherford clinical classification, and at 30 days it was about 93%, and at 2 years it was 96%. And freedom from TLR at 24 months was 77%. Primary assisted patency at 24 months was 92%. Secondary patency at 98%. So putting this all together, I would say that as far as the pave and crack strategy, we do have decent data for it. A lot of it is non-randomized. A lot of it may be outdated at this point because a lot of those studies were some of them were using data from 10 plus years ago. And then things have changed a little bit in terms of none of those studies that I mentioned about the pave and cracked had use of IVL. So those are the caveats. Last thing, Dr. Tsukos presented on this strategy at EVS, and he gave a pretty good summary that I just wanted to share with everyone. So calcified and complex disease often requires combination therapy with vessel prep with IVL and covered stents. We should use IVUS for vessel formology and sizing, and sometimes you have to crack before you pave due to the introduction of IVL with the low perforation rate. And if you can't get through the calcium, then the next option is to use the detour. All right.
Awesome.
Why don't you show them what we've been doing, Karthik? Laura? Oh, sorry.
Yeah,
I can't show them. So we got into a plane from below with an 035. The trouble we are having is I think we are right on top of the vessel. We are right on top of the vessel wall.
Stay right there. Yeah, let me see. Yeah, now we're dissecting again.
And then we are dissecting again.
I think we're into.
Here is a good spot. I think we are okay here, and from here I think the calcium is just pushing us out. So I think the plan is to balloon it and see if we can get the Outback from below.
I think the plan is now we're going to put a 6 French sheet from give me a 035 on what is it called?
Supercore. Give us a
Not a supercore. Actually, give me a supercore.
Yeah, supercore and a.
So what we're going to do is we're going to put a 6 French sheet from below, balloon from above,
you can put
Outback
an
re-entry from
5/6 slender from below.
Yeah, but we're going to put a 5/6
Yeah,
fellow.
give me an overnight wire, V18.
018, no, we may not be able to penetrate.
No,
Let's
but I
try.
think now we have an 035.
Yeah, 018 V18.
And give 5/6 slender.
New one right there. 5/6 slender. And we're going to do an Outback from below and balloon from above, right? Get a balloon, get us a 5/0 balloon from above. 5/0 120 balloon.
No, it won't go. Give
Yes,
6.
It will.
do after 60?
No. You need a long balloon to trap the wire. It's not about the length of the balloon.
Correct.
You need to trap the wire.
I don't think it will track the
It'll track. A 50 balloon will track, definitely. So get us a 50 120 balloon or a 100 balloon is fine. Because what you need to do is after you enter into the balloon, I need an 014 balloon or 018 balloon. 50.
Yeah, so PK, can you explain a little bit of what your strategy is once you have the balloon up?
So what's going to happen is, so we know that we couldn't get the, the B-back from above across the bifurcation. So therefore, what we're going to do is we're going to take this out, please. We're going to go ahead and put the 5/6 slender from below and go with the Outback from below because we don't have the ability to get into the true lumen from below.
How about using the B-back from below now? It's already opened, huh?
We could try that. That's a great idea. Let's try the B-back before you open the Outback.
Yeah, before you open the Outback.
Put the B-back in, guys. But the B-back is very small, Flora.
I know, but the idea, like you said, is just to connect that on top of the vessel. So hopefully, again,
Vishal,
it's
the
worth a
problem
try.
with comes with B-back is you need a good re-entry, right?
No, we still need a sheath.
Yeah,
we still need a sheath.
No, I'm not saying about the sheath.
Get us a 4-5
slender. Has to be there before you start.
Could you give us another angulation just so we can see how far off?
What's your legs?
We're right on top right there. You see that?
Yeah.
We're very close.
This is your LAO. I think up there we are far.
Down below we're good.
Down below we are very close. We can feel
that. We're not far. Get us a 4-5 slender, guys.
So I need 4-5 slender will not take the Outback. 5-6 slender.
No, we're going with the B-back.
But if you want to change it to an Outback,
you want to change it.
All right, get us a 5-6 slender.
Yeah, just go 5-6 slender straight up.
Yeah,
makes sense.
You have to change it one more time.
Makes sense.
Yeah, so Raman, your thoughts? So
yeah, the other thing is that I don't know about just ballooning it yet. I'm a little curious to see how far up your retrograde wire is going to go because you have the healthy-ish segment proximally.
So Raman, I think it will go on the top. We might be able to meet on the top. The problem is where the wires are crossing. I think we are very far away from the vessel wall.
So I think
that's the problem.
My question is that would it be easier to re-enter in a segment of the native vessel that's less densely calcified?
But the issue with him is the reason why it's densely calcified is farther away. You can see the wire, how it just deflects off the vessel. Right. So his concern is he's really into the adventitial wall, like really thin, which is fine. I mean, since the plan would be hopefully to put a cover stent in, we still should be able to get away with it. And if it works, we still have a cover stent there. That's why I asked the idea, how about just ballooning proximally distally like a cart? See if you have a plane and just punch a wire through, then all this Outback, B-back, all the stuff is off the chart, if we can get it. But
let me see if I have.
But I think before those re-entry, that's what we used to do is cart and reverse cart and try to create those two planes and go from there. Correct.
Okay,
but I think their biggest concern is the way the wire is behaving in that segment. It's way out almost into the wall. They're just concerned about a perforation at that time. So I think that's what's. So they want to enter pretty much like they're showing right up there. The two wires are closer and they start parting away. But let's see. I mean, like I said, it's a tough case, and it'll find the path of least resistance. And unfortunately, the path of the least resistance is way out in the vessel. So
the sheath,
we have to take it as
I think you pushed it through the lesion.
Oh, nice.
It's good. All right, we were able to muscle the sheath in, and now we're going to go ahead. Let's pull back the needle, guys.
My workout is working.
The needle has to come back, right?
Yeah. A lot of Pilates. Good job.
Pilates. I don't know about the Pilates part. I don't think it's going to fancy Guja do Pilates, but yes, workout is working. I'm benching.
We have some pictures.
We shall censor it.
Okay. All right. So the plan is, PK, you have
I got it.
Can you show the V-back catheter to the on your hand to the audience if you have it right up there, unless it's not in the body?
Well, it's just like an Outback. It's a needle entry catheter. That's all. Let's go.
That's fine.
Yeah.
V-back has a 7mm needle.
Yeah. The good thing is you can go straight as well as re-enter. So it's a directional catheter. So it helps you do CT as if you're using a support catheter. And if you need to re-enter, it gives you the flexibility of re-entering at the same time. So it's like a dual purpose catheter most of the times. And it delivers well. It's a
1 second, PK. Let me just
stiffer, but I don't know how they had the issues with ours.
Let me deploy the needle so that I can go ahead.
Yeah.
No, I don't think you need.
No, it will.
Yeah, it'll go.
You just have to tear through the vessel wall.
You don't want to tear the.
You might have to balloon a little bit before you deliver your V-back.
Yeah, it looks like it.
but the whole point of BBAC is we can tear through with the wire in place.
Yeah, that's what I was. Yeah, but remember, there it is.
Okay, you just have to go in.
Direct that.
Okay, give me a dive from above, Ray.
I don't think we're going to see much, but.
Why is it all? Are we in the profunda? Show me above. Show me above, please. Above, please.
Yeah. You want me to go in the other?
No, you're in RAO view. That's why you have to go LAO.
Okay. Give me now. Give me puff. Give me a puff. Take a DSA. Ready?
No.
You're good. You're good there.
No, it's just the angle.
Just trying to see how far away we are, like Raman said.
Not right here. Right there. Exactly where we thought.
Actually, I could enter.
Show me down.
You could enter
Show me down.
wherever it's feasible.
Right.
You're just
exactly where the wires are crossing.
Yeah, just going around the vessel.
You can enter right there.
You're going to put a covered stent anyway.
Yeah,
We'll balloon from above, we can.
You can do
just try to enter without
unexpected P-tab.
Unexpected. We are pretty much. There's such a small mini P-tab.
No, if you make a big lumen from the top, it might be easy, for you to fall in.
But let's see whether we can. No,
let's see how.
No, we're talking about poking in. So, Vishal, which side is the needle going to fire now?
The opposite side, medial side.
Yeah, it's going medial.
Yeah, fine.
Now, let's see.
Yeah, that's it.
You can mag up, yeah.
Okay, now let's see whether we can advance the wire into the lumen.
Yeah, I mean, usually
give me an 0-14 wire, guys.
It's going to
just pops right back out.
That's true. You need a sturdy needle or really have to physically
and also,
push the needle.
The bigger the lumen, the easier it is to do the Outback.
Yeah, so that's what I was thinking. If you want to do like PK was talking about, get a fiber balloon from the top.
Balloon and then puncture the balloon, PK.
Give me the command. No, I think right now we're pretty good, Vishal. I think because if we can't pierce the calcium with the needle, we're not going to be able to pierce the balloon through the calcium.
Through the calcium.
So it doesn't make any sense to do that. We can get a more aggressive needle, like we can go ahead and get a Stato or a different wire. But I'm seeing whether I've actually perforated the needle as such. And let's see with this wire whether it actually goes. And then worst comes to worst, we might have to do. We have a 6 French sheath here. And then decide.
The issue is you're still in the lesion per se, so you might still get a lot of
I would actually leave that catheter down there for now,
please.
Yeah?
So I don't think how much. The only thing that's going to save it is the balloon. Yeah.
Hold this. Clear up the back.
Yeah, this kind of case is just, there's a...
Permutation
and it's just a lot of poking until the calcium breaks.
Yeah.
And unfortunately, there's really no other way around
it. There it is. Yeah, keep it right there.
The other side. Yeah, I see you just got slid right off.
There.
Okay, let's go to another view here.
You want me to go in?
Yeah,
I'm just going to torque the B back a little bit.
Yeah.
We're going to take the needle back.
I'm trying. The needle's back now.
The needle's down, yeah.
Now let's try to torque it a little bit like that. And fire the needle now. Maybe that got in. Now I'm going outside again. Again outside.
Yeah, you might have to go a little bit more proximally, like push the catheter. It's all in the lesion. That's the problem. And it's so densely calcified, it's hard to find that true lumen in the lesion and then traverse through. It's not like a subtotal. That's the issue.
Give me an Stato here, guys.
Yeah, why are we
Let's come a little bit down here.
Lumen.
No, what do you mean?
It might be easy to create a lumen, right?
Oh yeah,
because there's a lesion again right in between those two catheters. That might be the reason even if you fall in, you're not going to know.
It's a CTO.
So if the wire goes in and you create a 5-0 lumen, it might be just easier to fall in.
No, there's no question. I'm just firing the needle.
I think we are firing into a very calcified segment. Even if you fall in, we might not.
That's what I'm saying. Even if you're in the vessel is occluded, so you'll never get the feel of a true lumen right there.
But the vessel is not occluded there, Vishal, because 035 wires, the 035 catheter is going.
There it is.
The vessel, the wire was out.
It's okay.
The vessel is not occluded. Give me the Stato, guys.
Right there.
No, let me just rotate. All right, we're going to have to do something different here. We're not going to keep doing this constantly.
Maybe fire half the way a needle if you see
it. Right there. Keep on pushing. But that time you got a chunk of the whole vessel.
Correct. That's what I'm saying. Maybe half a needle if you can.
Maybe
nice aggressive.
So I'm pushing the sheath. The sheath is actually coming back on us.
No, you're right. It's a very tough lesion. It's super See the dye still hanging there, right there.
So let's go with an Estado here, guys. Try. Try now. No.
No, Karthik, center it. I mean, don't
Yeah,
torque it.
no, PK is
Easier
pushing
said
it, so
than
I don't
done.
want to. No, PK is pushing it, so I don't want to.
So it's trying to take that path right there.
All right, so then let's try here.
And now turn it the other way?
Turn it medial, you know?
Yeah, no, laterally. Yeah.
Laterally, yeah, turn it lateral.
Yeah,
now fire. Now
Fire just a little
Hold
bit,
on, let me
Karthik.
push a little bit.
Yeah,
Okay,
not
now
too
try
much.
with the wire.
Yeah,
Nope, same problem.
With the calcium, it just keeps pushing it off.
maybe cross that. Yeah, if
You
you
try to
push
go
it
further up if you want.
Yeah, further up,
There's
exactly.
one little less hazy segment.
Oh, he's
Right.
having pain.
Okay, pull it back. Okay. Okay. All right, let's do this now. Let's get a
5-0 balloon from above.
no, we'll balloon from above, and then we'll try to pierce into the balloon.
Karthik, you want to give it a shot where you go up a little bit higher and fire it laterally?
No, Vishal, what happens is you're completely going away from the lumen there. This is a good spot where we cross the wires. So if you balloon it, I think you create a lumen. It might be easy to fall in.
I think it's a good spot in terms
To
of
falling
pushing
into
from the vessel.
Laura,
Yeah,
please.
this is probably the most
5-0 balloon.
unlikely,
Most receptive
area
part of the
to actually-
vessel, yeah.
to actually pierce.
Way far away from it, PK.
No. What me and Raman are trying to say is go a little bit higher up. I know you're far away, but the favorability is much better than the other side because you're going to balloon it anywhere. So
Yeah, just like 3
Right there.
centimeters up.
yeah, I think whatever marker 3 or something, whatever
Yeah.
All
between
right,
the two diamonds.
All right, guys, do me a favor. Let's do this. Give me a balloon from
And
above a
it's less dense
6-0,
calcium
508,
too.
Yeah.
018 balloon.
All right, I have a 5-0 here.
You mean the
but-
6-0?
Okay.
I want a 6-0. Get us a Pioneer from below, please, or an Outback from below. We'll try the B-back first. Is there a larger B-back, or it's only 4 French, all of them?
It's a 5-0.
Give me a 6-0. 560 is fine. 4 French is the largest. Okay, 6-0, 150 balloon.
PK, any reason you're skeptical about moving a B back to the tip of the wire where that is right now and then try to re-enter at a lesser calcified segment?
Yeah, well, there's no lesser calcified segment.
Relatively. What I mean to say
PK
is
is feeling that we're out of the vessel there.
I think you're not close. You're
We are
too
not
far
close.
away.
We're too far away.
And I think what we have to do is just be aggressive now with this, and then try to enter into the balloon with a B-back. How's the thigh, Ray? Okay. So when the patient is not reacting normally, that's because of the difficulty that how adventitious you are with the wire.
Correct.
So that's why for those at home, so at least you know why the patient is not happy when we're. Okay. All right. I think this is probably where we can, as much as we can advance the balloon here.
Little bit.
Let's see if it comes a little down.
Little
There you go.
That's perfect.
All right. Okay. Now let's advance this.
That's good, PK.
I just wanted to get the wire back.
Ooh, the balloon.
Now we can go forward.
That's fine.
Okay. Good. Okay. Go up.
Go slow. Just want to see how the
Now
patient
you're filling the
responds
whole
to
vessel, right? So
Yeah.
so now we're going to try to use the B-back to perf. So pull the B-back wire back a little bit. Let me just advance. Okay, now try to perf the balloon.
One second.
I think it was
No,
gliding
keeps
it was
back.
sliding on it.
Yeah. Wow.
Nope.
No.
I think
You have to
behind
perforate
the-
the balloon.
We're going to see it.
Yeah, you're gonna see the dye
Yeah,
go boom.
we did.
No, you can't advance the wire.
No,
till you
I'm
perf.
just saying.
Yeah.
I'm trying to get the feel of where it is.
Hold on.
I'm not sure you did.
No,
Yeah,
you're
I'm
hitting
pretty
it's
sure I did.
deflecting off.
I mean, you'll see it on the
No, pull back.
Angio.
on the indiflator.
Yeah.
As the pressure starts to come down. So the pressure is not coming down. Looks like it's fixed.
Now try.
Poke it.
Yeah. Wow. There.
No.
No,
No,
it's
that's
behind
fine.
it.
No, the balloon didn't perf.
No.
So I think you're right. It might be the Outback time or Pioneer.
Yeah, the B-back doesn't seem to want to perf the balloon. What pressure are you on with the balloon?
I am
at 4.
10. No.
Okay, try now. Pull the wire thing back.
I think the curve is, it's just sliding off the balloon. It's just going on top of it. Yeah, the curve of it, the needle is not as enough aggressive in this case.
You got to point it the other way.
Yeah. It's not moving at all.
Yeah.
Which is good in a way. That means you capture
the angle of the Outback's needle is going to be more efficient here.
Yeah.
Outback or the Pioneer.
Give me an Outback.
Yeah, it's probably the needle is just going parallel to the balloon because it's stuck between the balloon and the vessel. So it's not really
even like just the way how the needle comes out in the VBAC device versus the Outback and the Pioneer.
It's a different.
It's a single lumen that houses it that then goes
straight,
juts out. So it's going to follow that same trajectory.
Correct.
Whereas the Outback
comes
out from the side from a separate side.
Also, the angle of the Outback is
the needle takeoff is much
more
aggressive, acute.
I think you'll have a much better chance at puncture.
Outback or Pioneer, whichever you like, works. But
Pioneer may be better. But the problem is, I think the Pioneer may be hard to track there.
Yeah. I think Outback should be sufficient here. You have very good visualization.
Get the Outback, please.
Yeah.
You're out of the vessel.
Huh?
You're out of the vessel.
You're out of the. No, we are okay.
Give me the Outback. Outback.
Yeah, it's
So just in case, as we're approaching almost 8:50 now, I think this really highlights how challenging a case like this really is. Which begs the question because we haven't even actually discussed it yet. Would you have sent this patient? Well, even before we get there, would you have seen this entire calcium? Said just wash your hands of it and say, hey, what about bypass?
No, we could have done a P-tab, and that was the option. The option was a P-tab.
Flush it.
And I think the other option is to do a P-tab and stop, and then be able to do a P-tab. But I have a feeling we're going to get through. So I'm going to ask the AV team to keep recording. I know you guys are going to have sign off. But we're going to keep recording, and we're going to
have a few minutes. But in this case, probably keeping in mind the clinical history. The EF is 35%, multiple risk factors. We don't know the vein mapping, so I don't know.
I think a bypass is not an option. I think it's
vein mapping was done, Vishal. We had an option. We already did the vein mapping. It's great.
Why would you say bypass is not an option?
I'm not saying bypass is not an option. I'm saying I didn't know that vein mapping was done, and he's a good candidate.
No, it's just to discuss, on clinical practice or what are we should always, whenever going in for a procedure, know what's your plan B or C might be and discuss all the options. So it's a great case to do, and it's a hard case, but like Raman rightly brought up, you always have to have a discussion, which we do in all our cases.
But it's not even going into the sheet.
What's the nature, what's the presentation, and what's the outcome you're looking for. Are we looking up to heal ulcers? Are we dealing with gangrene? Are we dealing with claudication? So a lot of factors go into consideration, and a lot of team approach we do here at Sinai to give a true outcome to the patient. This patient, high risk, low EF, dialysis, multiple risk factors, significant calcification, might be a high risk for vascular surgery. But at the same time, we obviously want to make sure good vein. There's always a good plan B, like you said, to refer if this fails. We do have some options. Detour has now become part of our practice very commonly. So that's another good alternative. You can call it plan B/plan C versus just primary stenting and see how it does. So I think a good discussion about the patients, a team approach, and realistic outcomes probably gives the best outcome to the patient. So now PK can see is, that's the Outback.
Push the wire up. No, the Outback's not going because you have to put pressure here.
You want to take a 018?
The question might be you might have to balloon the track to deliver the outcome. So the Outback.
Let's try it now, Sheetan.
No, but it's not going.
No, it's very calcified, Karthik.
No, it's the problem is we need the
018 dilator.
We need the 018 dilator now.
Yeah, the angle.
I think there's also a kink in the wire there.
No, wire's not kinked. No, we need an 018 wire. Give me the micropuncture sheath again.
Is that a V18 you have right now, PK?
No, it's a command.
Oh, that's.
And give us a 6-French regular sheath.
Can I have an 018 micropuncture?
Yeah, we're getting it.
Yeah, I think you're right. Enough. Moving in for a stiffer wire will give you more support.
Directly, PK. Try this directly without it. of the floor?
Yeah, so a lot of steps, a lot of thought process, a lot of eyes needed for these kinds of cases. So yeah, it's like PK rightly predicted, it's going to take a full hour, and yeah, we're working on that.
It's not going.
Wow. You have a lot of blood flow.
It's going to take a full morning.
Give me a micropuncture sheath, please, with the dilator. That's what I want right now. Yeah. Please, don't ask me, just do what I'm asking you. Give me the whole sheet with the dilator in it.
I think it's also interesting that, the simpler cases, simpler we're using relatively here, right? I like how generally speaking, we're all pretty much on the same page, but these super complex ones, we're all having different thought processes, different devices, different wires. It's really interesting if you really consider, the amount of standardization that is lacking in the peripheral interventional space.
Yeah.
I think in
multiple ways to skin a cat.
There's so many ways,
Okay, give me a Trailblazer now. O&A Trailblazer. Let's see if a Trailblazer.
Job done.
Nope, Trailblazer will go. Give me a Trailblazer.
Oh boy. Oh boy.
I think we just go back with the dilator of the micropuncture sheet.
No, nothing is working, Michelle.
No, I get it. I'm just.
You have to change it to an 018 starter or something, and then.
No, I know, but PK said, we have to get something across.
There's a kink right there, right at the vessel. Yeah. If you pull that part of the kink back a little bit, you can get it inside the sheath, so you're not going to be pushing against it.
I think what he's going to do is, as he's introducing, if you pull it back, you just...
Exactly, yeah.
But yeah.
I'll suck even further. Oh, boy. Oh, tough.
Advance the wire more? Well, let me advance the wire from here. Hold on.
I did.
No, I can advance it. No, it's not going to go. I think the wire is very thin here.
That's it. Just give him the dilator of the...
inner dilator, yeah.
Just the inner dilator. Just give the inner dilator.
Okay.
And once you have that access...
Hold on a second. Let me just do something.
It doesn't matter if you lose wire. It's going to fly back.
Hold on. Show me down now.
You want me to give you the inner dilator?
No, give me the O&A Trailblazer.
I'll take the
inner dilator is not going to go if a Trailblazer is not going to go, dude. How's the inner dilator going to tell me? You need something to slip through. The inner dilator is very stiff.
Go for it.
Hold the wire slightly. See, it's not going through the tissue. You see that?
Yeah, no, I
okay. And see how the wire is damaged. So I think we have to give up wire position. Ray, just hold pressure here. We'll have to re-stick here. Come on the other side, Ray.
Before you give a wire position, give me 1 second.
Yeah, Karthik, yeah.
No, we're not going to give it up now. We have to re-stick. Is the stiff dilator?
Okay. Give me a softer, pedal access kit also. Push the wire up.
Wire's way up. Just hold pressure, Ray, for a second. Hold on a second. Let's see here. Let me try to push.
In moments like these, what usually happens, he just ends up crossing by accident.
Yeah, I know.
That would be wonderful.
We're going to push the wire and we just cross through it. Okay. And you pull the wire back, Karthik, and then...
I am.
Yeah.
Oh, boy.
Give me
wow, yeah. Yeah, I mean, so the way how you just had it, how you had the tissue elongated and the wire was
way back.
Was straight.
Wire is way
That's
back.
what I'm saying. The wire's back. It's just it's not going to work with a stiff thing here.
Oh, yeah, I think we're all done with this.
I think we have to re-stick. Let's re-stick.
So yeah, sometimes you just have to. It's hard.
Yeah. Well, okay.
You just try everything before. Yeah, you say re-stick. Yeah, no, I agree. It's just hard.
Give me a V18 from above, guys.
Yeah, I was gonna say, since you balloon from the top, you want to see if the wire, hopefully, by
just
chance.
Hold pressure for now. As he's holding pressure, let's get a V18 from above. So let me see, we're gonna try to come out from above here with a V18, maybe get into that plane that we were in.
Starter?
Yeah.
You want to 1.8 starter?
Good try.
Well, he wants to loop it. Yeah.
All right. So again, for everybody watching at home, we're definitely going to be keeping this case recorded. The juice and meat of it will be coming on after hours. So make sure we tune in to the CCC live cases website so we can make sure to follow up.
Fill in.
And see.
Well, let's see.
Yeah. Well, where are we going? Where is this going?
We might fall into the plane we created from below with the Outback, right?
So let's walk this balloon. Now give us a coronary balloon guy. Oh, it's an 018. Let me see if I can push the balloon.
So I think in this case it'll be better to balloon from the top and use an Outback from the top.
Let's get an 018 Trailblazer from above. Get an 018 from above. Work this out now. We're pretty far down. So work this out. So let's get an 018 Trailblazer from above. So the whole idea is creating planes, and now hopefully from above we'll cross, and at least we'll show everybody what we're going to do, and we'll stay on as we talked about. Mm-hmm.
Right now it's on the balloon.
No, we're walking out this balloon because this balloon is really destroyed.
Oh, okay.
So now I'm going with the Trailblazer from above.
You think using another balloon and try to dissect all the way down as the wire, give it support, balloon inflate, give it support, try to wire all the way down?
Problem is, Vishal, we're on an 018 balloon, and none of the 018 balloons are really going to cross from above.
Syringe.
What is he saying?
Yeah. But my goal, like you said, is just to extend that plane down and hopefully find a lumen to get back in. It gives you support as well as creating more planes.
Yeah, I mean, I think all these they're all viable ideas.
Correct.
But this is a lesion that is going to win 9.5 times out of 10. I mean, just keep on this. All you have to do is just keep on trying. I mean, if we're going to stick with the endovascular approach, there's all this whole laundry list of
things you can do
and steps and it just amount of how much time are you willing to give this. You know, this is 100% a crossable lesion. Just the time to cross is that's what the real challenge is.
So I think you can actually see as they have a microcatheter going down. Yeah, because remember, if this doesn't go down, then the Outback doesn't go down. So you really have to dissect all the way down, or balloon all the way down, and then you get the Outback through the stuff. But look at that.
That's the pain? Okay. Get us an 035 Navicross here. And then get us a new straight glide wire.
What was the anticoagulation you guys chose?
Navicross. Just heparin.
That's heparin.
Navicross, guys, heparin. We knew this was going to be a painful case.
Yeah.
Navicross, we have the Navicross here.
This is 035.
I like heparin for cases like this because in the unfortunate event if you can't cross, you know, it kind of could facilitate the closure and kind of wrapping up the case by just giving it some protamine and just calling it a day.
No, I think we're going to cross. I really do. It's just a matter of, unfortunately, we couldn't do it in an hour here.
We don't say no at Mount Sinai.
Yeah. No, man. It's like you rightly said, right? I mean, it's not about the hour. It's about the safety. It's about doing the right things. It's about recognizing issues. So
go with you,
I think in these kinds of cases, you should block your time and don't restrict your time.
I mean, like if this when this last angiogram was done,
you already knew what
at the diagnostic.
Correct.
I mean, that is out of all the things being suggested so far.
Get us
that
a new 035 wire.
Correct. 100%. I agree with that point.
Take the patient off the table and stop and think and plan.
Correct.
You know, I think seeing that first angiogram, 100% stop.
That's true. I agree. I think that's a good strategy.
There's a lot of
half of that.
We'll take it as it goes. Yeah, I agree. All right, so PK, you have an 035 system now going down?
Yeah, we're going to try to get into that plane with an 035. Me and Karthik, the 018 didn't go. So the next thing will be
I agree.
Let's see whether we can somehow.
We'll give this about a minute or so, and then if it's not
there you go.
Right there.
Okay,
there
we are.
Okay, try Karthik if you can. No, and not going. No, you're not pressing. Karthik is trying to. Watch the sheet above, guys. Let's see the sheet.
Yeah, multiple things to look into how the sheet responds. Yeah.
Track the sheet down. Yeah, that's good. Okay. What's going on, Ray? Where is he feeling it? This won't go, huh?
Rock.
Okay, now I'm going to pull this wire back. Give me an 014 wire now. Give me an 014 command. Let's try to get the command into that hole. So you guys can sign off. Yeah. We'll stay on. David will stay on virtually. And AV team, we're going to stay with us for this one.
All right. Well, guys, Dr. Krishan, Dr. Guja, Ray, the team, Guys, this has been a really. I wish we could have extended this hour to maybe make it like a holiday special, have a 2-hour, 3-hour show for you guys. But unfortunately, time is not always fully available to all of us. But again, from Mount Sinai and Dr. Krishnan's team and I, we would like to wish you a very happy holidays. Enjoy your time with your family, time off or time working, depending on what you're going to be doing. And Happy New Year. And once again, keep in mind that the rest of this case is going to be available online. So make sure to check it out to see how Dr. Krishnan and then Dr. Guja end up finally finishing this case. And we will see you in the new year on Wednesday, January 28th. Yeah. All right, the last Wednesday of the month. And that wish you, we cross. It's
all right.
Christmas miracle. Christmas
Let's
miracle.
go now.
I want to see it.
Let's revert back.
I want to see it. I mean, this is what the holiday season is.
See, that's how we start. We have to threaten them on closing the show down.
Yeah.
So, all right. We'll be working. We'll be working, and we'll see you guys.
So what cross, PK? Can you just tell us what wire?
I think the dissection, and then the command found the lumen distal and went right in.
Outstanding.
All right. So now we're going to balloon, and we'll do it online.
Great.
So Ray's going to hold pressure here. So thanks again. Give us what do you got?
All right, guys.
Yep, 3-5-30.
Guys, this is what the holiday season is all about. Miracles. I love it. All right. So with that being said, once again, happy holidays and happy New Year from Mount Sinai, our endovascular team. Wish you all the very best, and we'll see you in the new year.
Happy New Year.
Bye-bye.
Thank you. Bye.
David.
I'm still here with chat. We're still live.
Okay, so I want to tell you, so for the people on the chat who are watching, please record the whole thing. Continue transmission, please. So as now what we're going to do is balloon the track. So is it going?
Not going.
Not going, huh? So we're having trouble ballooning this is the corner.
Case for,
Get us a Takaru 2.0.
Okay, this might be a good case for, what is that?
No.
The shockwave thing.
Takaru 2.0, please. Walk it out.
No.
Where is the pain?
Can we give him something in the groin?
Huh? Okay, squeeze it. 20, please.
Little pressure here. Just little pressure, Pascal. Just hang in there,
buddy. So David, why don't you moderate as we go forward? So what we're doing now is we can't cross it. We're going with the Takaru 2.0. So Takaru 2.0 to try to get through. If the next step will be going with the Trailblazer, and then we're gonna, as you can see, the wires cross down below. We're definitely in the vessel below. That's the occlusion.
That's your occlusion, yeah.
Yeah. So can I have the floor, please?
Yeah.
So what we're gonna do is we're gonna go with the 2.0 balloon that track, and then we're gonna go ahead and start. And the plan here.
I summarize that for the chat.
Yep. That's fine.
That's good. Then we'll leave it for now.
I got it. Mm-hmm.
I'll wet it for you, PK.
It's wet.
Yeah.
Well.
The chat did want to know, for these type of cases, did you guys upgrade the seat up front, or are we going with the 6 French here?
No, we're at a 7. Where is it? We're at a 7 French. So the Takaru is trying to sneak through there. And there it is. That's it. Stop there. Let's balloon this.
Save it.
And
So the Takaru is a Terumo balloon for those of you at home. And we're just going to balloon this track here.
Oh, tight.
So that's the ballooning of the track. Save that. So it's at 20 atmospheres. Go again, Karthik. Go forward a little bit.
I got it.
Hold on. Let me just give you the rail. Good.
Everything
Let's balloon there. Get us a maybe have a coronary guideline already. Okay.
Ooh, ruptured.
Balloon ruptured, which is good. Now get me a Abbott 25 60 balloon. Abbott 2560 balloon, please.
018, 014.
No, 014 2560. So right now we're still ballooning this track because we need to get a big track to get an 035 wire down and then balloon this really, really well. to create a ability for our crack and pave.
Coronary case in room 4, can you ask? Thank you. Hang on. I got this.
Yeah, I got it.
I'll give it to you so you can hold it. It's easier.
Mm-hmm.
Really? For me? Wow.
No, doesn't want to go.
No.
Abbott balloon does not want to go. Only the tacker is going. All right, get us a guideline and a coronary balloon now. 6-0 guideliner.
And give
or
me
7-0.
a
Give me a 7-0 to be careful.
And give
Where's
me
our
a
sheet? Check our sheet.
4 coronary balloon.
No, go with the 3 first. Check our sheet, please.
Yeah, sheet is okay.
Check our sheet position.
I just checked it.
You did. Flush the guideliner. So this is another technique that we can use. Okay, get us a 3-5 coronary high pressure balloon, please. Right, you were compressing, right? Okay, hold the distal edge, please. Let's go. Yeah. What's
He gave a lot of lidocaine, so it's not hurting him anymore.
Good. Now give us the balloon, the 3-5 balloon. So the guideline of, where's the 3-5 balloon, guys? You gave it to us? Yes. Okay. Where's the balloon, Navad? That's not the, is that the 3-5? Coronary. You gave us the coronary balloon? You can try it.
It won't go. To the guideliner, it won't go.
Yes, it will. That will go. I've done it.
Oh, is it?
Where's the 3-5 coronary balloon? We gave it to you. All right. Awad, go there and hold pressure. Yeah. Ray, come on this side. 3-5 coronary balloon. Give me what you got. It's fine.
Yeah, that's fine, bro. It'll go. Everything will go through it. The guideliner is like right there. Come on.
Just hold pressure, please, in that spot. Make sure he's not bleeding.
Right there.
We'll hold the distal edge, please. Distal, please. Go.
Wow.
No?
Shaft is bent.
The shaft is bent.
Oh, not great.
No. All right, get us a 2-5 coronary balloon.
It's crazy.
Coronary guys? 2-5 coronary guys. Let's try this. This is the Abbott balloon. Let's try this. No, this has already been deployed. No, it hasn't.
Okay, perfect.
You can go. I got this.
No, it's okay. Patient is not in the room yet.
So, David, any thoughts on what you would do?
So right now, the chat is saying, they're talking about the difficulty of the guide support and everything. Someone did bring up a cutting balloon at the Rodney, but then we're talking about deliverability and support here, so that may not be the initial great upfront choice. But, the chat is coming up with some great suggestions right now.
There it goes. Let's balloon there.
Little bit. Try it.
There it goes. There it goes. Good. Now walk the guideline back. Try to see if it goes.
No, I want to see.
No, you ruptured it. You ruptured it.
No, PK. I didn't touch it. No, it's already there. That staining from the previous balloon.
Okay, good. Stop there. Good. Let's go up now.
Crazy.
Nice.
At 20 atmospheres, pull back a little bit. Hold on, let me pull it back. Walk back.
Get the guideliner also back.
Walk back. Okay, good.
I'm going to see if I can put the guideliner over it.
That's what I was just going to tell you. Hold on. Let me expand it. Hold on. Okay, go.
When you deflate, let me know.
Ready to deflate?
Yeah. Ready to deflate?
No. Will the Navi Cross go through this, you think, now? Okay, get us a 3.0 Abbott balloon now. Stay right there. 3.0 Abbott balloon.
You want to try the 4.0? Okay, 4.0 and 3.0 are the same profile. Give a 4.0. They have the same profile. Shorter the better.
It's fine. And get us an
over the wire.
Get us an 018 balloon next. We'll change out
over the wire might be better. No?
It is over the wire.
No,
that's fine. Let's go with this for now. Get us an 018. Maybe you show pressure. I don't know if you're properly. The wire's down there. No, it's in a branch. It's okay. Try to get it in the. It's fine. Let's just get down there. We'll be able to get through. You're in the branch though, Karthik. It's fine. It's coming to you.
Yeah.
Good. Stop there. 4.0 balloon going up.
Go for it. It's tight.
Save it. And now try to take the guideline over this. Down.
Nope.
All right, let's get a Navicross. Maybe a Navicross. We can get it down there now.
You want to balloon?
Or actually, give me an 018 balloon now.
You want to balloon the track and see?
Yeah, let's go all the way down now. Down. Hold on. See if it goes.
Okay.
Okay, good. Let's go up here. Good.
Yeah, we are in the lower.
You're in the vessel. Good push. Push. Good. Loop it. That's good. That's perfect. Show me above. Show me above. Okay, good.
One more.
Go forward a little more. Go forward a little more with the balloon.
Wire is bending.
Don't bend the wire. I didn't bend the wire.
No, just bending.
Okay, good.
You want to change to a new wire here?
Yeah, give us a new a Spartacore.
Down.
Yeah, advance a little more. Our Grand Slam is fine, whatever you got.
Yeah, I think that's good. That's it. That was fun to cross it online. Let me get it down.
That's fine, that's fine, that's fine. Good, that's fine, that's plenty.
You want to balloon that area? You're
that's
there.
Fine,
You're there. No
balloon here. Get us a 5.0 balloon now.
1 second, PK. Hold it. Do it as a rail. Let me see if I can push it.
Your sheet will gonna come out. That's fine. Leave it there. That's good.
Let me
see. That's good enough.
1 second. Let me get the. Let me
sheet
hold it
good.
as a rail. And
sheet is good.
And let me see if the rail will pull it. Pull back on the balloon.
We got to watch the iliac, Karthik. You can't do that. You'll rupture the iliac. You'll avulse the iliac if you do that. Don't do that. That's not a safe thing to do. Look what happened to the pressure. Never pull on the iliac. To those at home, never pull on the iliac. 5.0 ultraverse. Yep. 5.0 80. 40 is fine, Flora. Okay. They stay right there. Don't walk back the sheet.
No, don't walk back the sheet.
Nope. You just want to expand this. Okay, now let's go with the 5-0 balloon.
You want me to see if I can push in over this?
I don't want you to, with the iliac, I don't want to mess with the iliac.
No, not the iliac.
You know, when you're pushing, the iliac is feeling it. Don't do anything with the iliac, please.
Okay. Okay.
All right, now give us an 018 command. I mean, a 018 V18, a new one, and then we're going to go with the 01850 balloon. Get rid of this balloon, brother.
Leave it. That's it. Just a little bit.
A little bit. It's
a little bit more.
We're almost done. Once we get this through, we'll put a covered stent in and I'll stop.
This is 5 or 6
This is 5. It may not go through the guideline.
Yeah, it's not going.
May not go through the guide. Do we have a 50014 balloon?
Yeah, we have.
Give me a 50014.
Nanocross.
Show me down below.
I'll pull it. You push it.
We have a 50014 balloon or no? And
yeah, that's fine.
Save this.
After this, we can put a Trailblazer and then change it to an 018, no?
Yep. No, we have the Navicross.
I got this for you.
It's coming. You don't lose the wire.
Pull.
Not going through that? All right, so then you have to walk that out. Yep, that's the problem. Okay, let's walk it out. Yeah, walk out the...
Yeah.
Okay, walk that out. No,
we'll walk out the guideliner and then we'll try to put
the 5-0 balloon.
5-0 balloon over it.
Give me the 50018 balloon now. 50018 balloon, right?
018 might not go, PK.
Let's try.
Because a guideliner didn't go, right?
No, we didn't try it. No, guideline is 7 French.
I know, but still the profile.
Profile's huge.
We'll try.
Try, exactly. We're...
Worst is take it out and put it back
in. Go.
That was so
shit.
No, same part.
No?
Nope.
Okay. Give us a 5014 balloon now.
Nanocross we have, right? Yeah.
Nanocross is not going to go.
No, the one.
Yeah, Nanocross balloon we need now.
Yeah.
50 Nanocross, right? We have a 50 coronary balloon, guys. Get a 50 coronary balloon ready. Give me a 50 Nanocross, right? No, you gave me the Nanocross didn't go? Oh, the Nanocross didn't go. 50 coronary balloon then? Put back the Trailblazer, go with the 50 balloon. I mean, put back the guideliner, go with the 50 balloon now. You want to do that? Yeah, let's do that.
I know you guys are, working hard to open the track, but a good question from chat is for these long covered stent segments, do you change your surveillance regimen, or is it still pretty routine?
It's going to be pretty routine. We're gonna do the same routine that we normally do with these covered stents. So the problem we're having is we're not able to expand that distal anastomotic site or the dissection site, and nothing is going. So we're going to have to really be aggressive and maybe do a 50 coronary and then a 60 coronary, and then take it from there. So so the idea would be that. Hold on, let me get a fluoro. So yeah, I mean, as far as our strategy, Ray, push it down, Ray, my elbow's
I got it. I got you.
So you see, that's the area right there we're struggling, David. We're not able to get anything there. See, right there, we got to crack that. We got to break that. So now we're going to go with a coronary balloon, and then probably a 6015 Viatrac, and then really try to smash this, even perforate it if we have to, and then go forward. Not yet. Let's see how this one does.
The recoil is insane. My wire shaft is breaking.
Okay, let's go up here. 20.
No, it's in the sheet.
No, walk the sheet back. Now track the sheet down over it.
Yeah.
Down. Now try to track the sheet over it.
Nope.
Sheet's not going over it?
No, the guideliner is not going over.
Really?
Yeah. Second.
Definitely going a little bit.
Go up again, right?
20.
Down.
Down. No?
It's laughing at me.
Let me get it, Phil. There it goes. Yeah, we definitely went.
Nope.
Wire, watch your wire. Okay, down. Show me above. Yeah, let me see again. Let me get a feel.
What if we put an overnight trailblazer and then change it to an overnight wire? It might be just the stiffness of the support issue, right? Overnight trailblazer. Snap? Yeah, I thought so.
Oh, 1-8 Trailblazer, guys.
I have it right.
Or the next thing you can do is give me a 018 Navicross.
This is 018 Trailblazer, right? Yeah. It's crazy. Wow. Whoa.
018 Navicross will go. Navicross, guys.
You want to take the wire out? Or?
No, I don't think it'll cross. Yep, and give it. Just give it. It's fine. We're fine.
Only thinking if you perf, it's okay with less heparin. That's the thought process. Yeah, that was a good thing. Thank you. Now we're giving you the thought process. Is if you perf it, at least if it's less heparin, we can always give more heparin. So. Okay. Got it?
I hope the Navicross goes. It should go.
Sure, it's a little hydrophilic. So much roughness on the wire. You want me to twist it? Want to see if it goes?
Hold on, rail it now.
Yeah. There you go. 018 V18.
Nice.
We might have more support.
Okay,
now.
good.
Oh,
I'll
the
give you the
wire went
V18.
through.
That's fine.
Then change it to an 035 and then go crazy.
What 018 balloons do we have? We have the
We have the ultraverse.
You have a 4.0? That's fine. Show me above now. Or 080, please. It won't go through this sheet. I have to take out this thing now. Why is there so much tension on this?
Yeah, it's just probably because of the overnight system.
No, there's no system.
No, it's no tension.
Okay.
Also, it's bent, right?
Okay.
The guideliner is bent.
V18 we're at, right? There's a V18?
Yes.
Oh, you still have that in there, that's why. Got it.
Mm-hmm.
So much. Want to balloon it there?
Yep, balloon it here. Balloon the shit out of it. Get a 5 already, guys?
Yeah, go for it.
Mm-hmm. Well, yep. 20 atmosphere.
Yeah, that's it. We broke it. We
Save
broke it. Yeah. We cracked it.
Yeah. Down.
Just change it to a 035 system.
No, not yet. Let's do the 5.0. Let's not get crazy.
No, I'm saying,
Just give us a 5.0 ray. Walk.
go in there, go in pick.
Uh-huh.
That's good. That's good. Let's
Go up
balloon it.
again. 5.0 120 is fine. Good. Yeah, you're adventitial. You're gonna perf. That's fine.
Yeah.
Just got to get this down. Mm-hmm. See, now you're bleeding.
Go back in.
You want to go up?
No, I'm saying you want to go back in and balloon it, or
You want to go down further?
Yeah.
Wait, this is okay, you know? Okay.
Saying you want to, if you have it, you create
Okay,
your
go.
track.
Go
No?
up here. Yeah, you can save this one. There you go. Okay.
Yeah.
And balloon the top again. Watch his hands, guys. Nurses, go up again. No, hang on.
It cracked.
20. That's fine. Down. Walk it out. All right, give us a 5.0 ray. Well, we're going to have to go with an 018 system because
Of the Viabon.
Because of the Viabon.
Yeah.
So get me a long Viabon now. 6.0 long Viabon.
Popliteal, what do you want to do, Pika?
Well, initially, let's get this sealed first.
Yeah.
Give me that. So, David, now we're going to try to get the Viabon down. We're going to do a 6.0, I don't know, 250 Viabon all the way down.
Given your all's experience, given this degree of calcium, do you all have any experience deploying an IVL within a covered stent to further enhance expansion?
There is absolutely no role for
role for
IVL
IVL.
within a covered stent.
Yeah.
And I think if anybody tells you there is, I think the mechanism of IVL, they don't understand totally the mechanism of the IVL.
I don't know, based on the mechanism of IVL, you might actually destroy the covered
Go
stent
up.
lining, so.
Careful, he's going to hurt now. Mm-hmm. 150, 250. Don't open it yet, I'll tell you when.
Can we give him some more sedation?
More pressure.
Breathe, my friend. Breathe. Take a deep breath in.
This is 100?
This is 150.
Down. Gotta go down a little further.
Yeah, I'm going to pull it back, and then you can go further a little bit. But we can deflate it. That's the problem.
You're not railing?
I'm railing. Tight. Maybe put it here.
Go up here. Get us another 60, this balloon. Yeah. Yeah, down. Okay, down. Okay, walk it out quickly.
Yeah, it's not deflating.
It's not deflating?
No, I mean, it is slowly. It's still inflated, right?
Go up here. Let's balloon this area. Okay, down.
Much better.
All right, guys. Go negative again.
Oh, sorry. Sorry, I'm so sorry. So sorry. Give you a shower. Tight.
Don't bend the wire.
Yeah, I just want to make sure where the wire is.
All right. In a second,
Tight.
we're going to give ACT, guys.
So tight. Oh, man. I think the iliac is not helping too.
Okay, give me the balloon. One more second. Give an ACT.
Ray, hold the wire.
He's coming to him, yeah. Big floor, Ray.
ACT.
Watch the wire. Okay, balloon here.
Take some dilution.
It's okay, we don't need it now.
Oh, that's tight. Yeah, block. That's crazy.
Okay, down. You walk it back now. Let it come down. Watch the iliac.
Diluted it.
Balloon this, a little higher. A little higher. Okay, balloon this part. That's fine, that's fine. He's gonna hurt him.
Can you take this once?
What happened?
No, I just want to tell them.
Okay, down, down. Okay, walk it out now, Ray. Get us a vibe on now.
So 250.
Open that. What's our ACT?
Oh, great.
What size is this? No. What do you? Jesus. All right. You give me a VBX. What, Ramon? It's a Viabon. I need a Viabon, not a VBX. Okay, then get the 25 centimeter Viabon here. I need a Viabon, not a VBX. Get it over here. It's over here, right? Oh, you got it there. Oh, okay. Thanks, buddy. Perfect. That's fine. Give me. Well, you don't have 20. You should have 25. You should have 25. No, it's not 250. 2.5. Is there a 25 centimeter Viabon? Yeah. Thank you, my dear. That's fine. That's fine. No, don't throw that out. We might need it. Yeah. I was wondering why it crossed so easily. I was all happy. I was like, oh my God, Ramon, this is awesome. And then of course, he has to be a Dodger fan and screw me over. That's all right. Leave it for now. We may still need it, Ramon. Hopefully it goes. That went easy. Hopefully this goes. No, I got it. No, I don't think so. There you go. That's fine. Are you really? I don't. Fuck. Nope. Oi. Hope you don't perf down there, brother. You walk this up. Get us a 7.0 balloon now. All right. Get us a shorter Viabon now, like a 150. We need a 7.0 O&A balloon now. See if this Viabon's okay, Ray.
Just a kind reminder, we still have live engagement. Everybody's on the end of their seats right now.
Yeah, we're not able to. What do you have? 0.8? 7.0? What size? 120. Give me a 120. No, die. I mean, you're going to bleed up top if you give die now. You're definitely bleeding up top. Just feel under there. We'll see how it feels. And get us a 150 Viabon now. Yep. Have it ready. Just watch the wire, Karthik. Okay, let's go up now. Okay, this is going to hurt him, girls. Is he tachycardic or is it me? Okay. I mean, what are you going to do? You got to get it down there. Show me. Show me down. Oh, that's fine. That's fine. All right, down. Down. Let's see if this goes. Give me the 60155 on. Rail. I just want to see if it goes down. I'll walk it back out. Let's see how it goes. Yeah, you can open that, but I'm going to go with the 250 first. Go. Yeah, no, come out. Come all the way out. And then let me try to push it in. Okay, now, so for everybody at home, we're just testing to see how the deflated balloon went, no problem. A little bit of problem, but not bad. So let's try the 255 on. That's fine, wire's good there.
Yeah, please.
Oh yeah, don't delay.
Yeah, don't delay. Yeah.
Somebody's not coming? Not coming?
I don't want to bend the wire.
I'll push the wire down, don't worry. Okay, give us the vibe on again. I got a C loop, which is nice. That's good, let it stay there. All right, let's go with the, let me see where my sheet is now. Move it on my sheet. I know. Where's my sheet? Where is it? Right there. Okay, okay, that's good. Okay. Are you railing? Because it's bending in the sheet. Okay. Okay. That's good. Show me above. All right, let's get the 150, guys. 250 is too long. Get the 150. Yeah. Sheet is good. No, it's right there. Sheet is right there. The wire is good. Come. Okay, 150. This Stent is out. Let's just keep it though. And then what do you have? You have another 150? Go. Don't open. Don't open. Keep railing. Okay, let's just deploy here. Agreed? Yeah, let's deploy. Let's deploy, and then we'll come back with the other one. Go. Mm-hmm. Okay, good. All right. Walk it out. Mm-hmm. Go ahead. You push, I'll pull. Mm-hmm. Mm-hmm. That'll come. Mm-hmm. That's fine. Mm-hmm. We should be bleeding at the site of access now. Let me just pull this. Mm-hmm. Yeah. All right, let's just take a picture now. DSA. Ready? Look out, look out, look out. Avoid. Step away.
Yeah.
Ready? Inject. Okay, you coupled the injector, guys. This is injector not ready. Armed injector. Let us work together, please. Ready? Okay. Still bleeding there. We got to get something down there. It's just going to become a pseudo. All right, let's first balloon this now. Let's. Well, I don't know if it'll go. We have to get a shorter one. Get us a new 035 wire here. I mean, a new 018. Actually, this is fine. This is fine. Give us a. Yes, I don't think it'll go. I think we have to balloon the proximal first. Give me a 80 balloon first. We gotta get this. It's not bleeding. It's just like a. It's not bleeding. I'm gonna balloon the shit out of it now. He's gonna hurt like crazy, guys. Yeah, but first I think we have to balloon this. Make sure he's not bleeding down. I move this. I can't move my elbow. No, down below, down below. Where the wire was fucked up. Ready? Inject. It's not done yet. Perf. Perf.
8080 and 035.
I think it's a perf, no? The whole thing is not a perf? Looks like a perf to me. It's not expanding. It's a dissection, huh?
8080 and 035.
Okay, that's fine. No, okay. It'll close off.
Yeah, it's good.
All right, ladies. This one's gonna hurt him much more than it's gonna hurt you. All right, get us a Supera now. 6-0. 6-0 Supera.
How long?
Actually, you know what? Yeah, 6-0. Give us a 6-0. It's a 6-0, right? Maybe a 5-5 is fine. A 5-5, 100. Inside the Viabon. Show me up top. Get rid of this shield, guys, so I can see. Oh, it's not a shield. Oh, there it is. You're railing me? All right, let's stop right here. This is where it's really not expanded. Okay, this one's really going to hurt. The 80. Okay, go up slow. Mag it up, Ray. So this is the classic crack and pave. 10. 10. Breathe.
One way to do it is we can give
lidocaine.
Lidocaine there.
Yeah. Well,
Can I have some Lido? This is all Lido? Or?
Yeah, that's all.
How much is the ACG?
Or we're giving lidocaine now for everybody at home. We should have done this before. Right around. Laura?
Is it better, Pascal?
No names.
Is it better, my friend?
Laura? Okay. 20 atmospheres.
Some more lighter, please.
Laura? All right, get us a Supera now. It collapsed that much, really? Not really, it's better. No, it's better, actually. Get us actually, you want to do a 5.0, right? 5.5?
You want to do a Supera?
You want? Yeah, you have to look at it. You want to braille this?
5.5, 150, 5.5, 100.
You have to put a Supera card there. You can do a 6.0. 6.0. 6.0 is too much. Give me a 5.5, guys. I know. Flora?
5.5, 100.
Yeah. Show me. You're good. Mm-hmm.
5.5, 100.
Yep. No, you always put the cover stents in first.
No, I'm saying, yeah, I mean,
You want to put a distal cover stent? All right, give us a 6.0, another 6.0, 150 covered stent. 100 is fine.
100.
I don't think we need one proximally, do we?
So, Dr. Krishnan, just to summarize, the plan is to distally place a covered stent and then lay an inline of Supera to kind of prevent the recoil. Is that correct?
Yeah, because the recoil is bad. I ballooned with an 8.0 at 20 atmospheres, you saw. And with that, you have this issue. Yeah, that's what I think. I think up top, we're just going to put a regular stent. Ready? Let's go. Or a silver. Mm, 100%. There's no chance. Can't do it live anyway. It takes too long. All right.
One time, cartridge
Laura? You're on, Laura? I think that's good. No, but this is good, though. I just want to cover the area we got in right there. See, that's perfect. Okay, go. Mm-hmm. What? Deploy this, buddy? So when you deploy it, you just fix it and pull it with a...
Yeah,
he's done it, of course.
Yeah.
Nice. Beauty. Nice. Very nice. Okay, let's walk this out now, brother. Go ahead, walk it out. Feel the tension.
Yeah.
Okay, it's okay. Get us now the Supera. Yeah, I just want to get that really compressed spot. It's going to elongate. We know that. We're going to try not to. I mean, we prepped the whole thing with an 8, so hopefully it won't. Supera.
I'm going to give the whole leg.
No, this you won't feel.
No, I'm just saying, we have to balloon it anyway.
Yeah, ballooning on it. Yeah, I think it'll be okay.
Go back with the same 8 or you want to give me one?
I think it'll be fine. Go with the same O.
Same one.
That's what I mean. We'll do a final. I don't think you need Lido now. He tolerated that just fine. Come on. He's a man. He's a tough guy.
Why give it 10?
He's not like you.
Oh.
He's a tough guy.
Actually, that might be. I don't tolerate pain like that. You keep hurting me all the time.
Up top. Oh my God. You're not.
Won't I? I'm still standing in Mount Sinai.
No, you're not railing. That's right. There you go. Okay, let me see now. Let me see. Mag it up, guys. Let's mag it up. I just want to see it.
Well, that's just.
Yeah. I think we got to go down. I think that's good. Right, maybe a little bit further down.
A little bit further down.
Finish.
No.
Down on
Yeah. Okay. Who wants to do it? Me? Okay, good.
Good luck with that.
Can you mag? Is the most mag? Did it deploy right? I can't see it. Where am I? I can't even see the damn thing. Oh, positive. You want to really be slow. Be slow. Is it deploying? It is, okay. I can't see it. It's unbelievable how difficult it is to see. Yeah, now I see it. Get us a 6015 Vitrac. Actually, 70 if you have it. Actually, no, we won't shockwave. I just want a 80, another 80 balloon. Yeah, no. Oh, you're elongating. Yeah, I see what you're doing. You do a lot more of these than I do. Yeah, like that. That's what I like right there. Yep, that's what I want. Yep, that's what I want. What's he complaining about, ladies, please? I give 2,000. Try to stack. Got a little bit more to go now. Got all the way. I got to go all the way up there. You have to go all the way up to where it becomes fat. So you're going to run out a little bit. You can pull it now. Yeah, exactly. Thank you. Now pull it a little bit. Okay. Yeah, give us an 80 now. Mm-hmm.
This is 100, right?
Yeah. Get rid of this Apera. 80 balloon. The fellows can deploy it. Well, mm-hmm. Okay.
Hold the wire.
Yeah.
No, it should go. All right, get us an 035 supercore.
Have it right here.
We have. That's fine. Leave the new one. Sorry. Advance the balloon, please. Advance the balloon. You want to go do the left main now? Go right there. Okay, that's fine. That's fine. Laura? What's nominal here, guys?
6 and 13.
Show me above. Show me above. That's good. $20. Floor is safe. Off floor. How do you floor save? This one? Show me. $30. I think we're done. Yeah, take it out.
We're almost done. We're almost done, my friend. We're almost done. You did a phenomenal job. Great job.
Okay, DSA. DSA. Cindy. All right, let's get a Zilbert PTX now. Long. 120 is fine. 60 is fine. Let's do a roadmap here, Karthik. Flora. I think 120 should be good. Should be perfect. Tough case. So we're gonna put him on NSAIDs.
He's on aspirin and Plavix already.
Yeah, we're gonna have to give him lots of NSAIDs like Mobic, or I'll even give him Ultram tonight.
Oh, I thought you meant okay. Yeah.
No, tonight. So I would give him Toradol. Can we give him some IM Toradol now? IV, whatever. IV, IM. You're the nurse. I'm the doctor. I don't know the route of administration. I know the drug. I know the drug. You're laughing at me. Toradol. Toradol will help him. We could, if it was a PTAB, would have done it.
PTAB, yes.
But I mean, this is a good case to edit and put it on our website. It's a great case. It would not have worked.
No, I'm just saying, like, if you would have stopped trying from BBAC and once we created a track, we would have tried from above, I think it would have been fine. Because we created a path, right?
Agreed. That's what happened. That's what happened. Yeah.
Instead of trying from below, we should have tried a little bit.
Oh, no. But to get the B back in, we had to put the sheath, huh? 140.
No, the sheath is fine.
No, I'm talking about this. 140, right? Karthik? Yeah.
140 is fine, yeah.
140 is perfect.
also okay, but if you have 140, 100 will not be enough.
100 will not be enough.
Cutting very close.
David, any comments so far?
No, just everybody is very impressed by the patience, the teamwork that we're really demonstrating for this complex case. They're very happy that we're able to deploy the Stent and expand it fully. I've been walking them through the steps of what the thought process is here, and it's a great case. It's a great case, great teamwork.
Let's start with total for the inflammation, then we'll give. Then you can give them some fennel. That's great, David. So we're now controlling the pain to let everybody know, because of the pain at home in the thigh is going to be tremendous, because I ballooned with an 8, obviously. So obviously it's a tremendous amount of pain that he's having. So now we're going to go with a 1 to 120. There's the top and the bottom. So we can puff out because we're in a 7. So off roadmap here. So Karthik will start deploying, and we'll go to the proper view. Ray, can you go to the proper view, buddy? Go more REO, and then mag it up for Karthik, and then we'll give some dye. Just all we need to do is look at the ostium, because we're covered distally. So little dye. Yeah, that's perfect right there. Let's just deploy it there. So as Karthik is deploying, Ray's going to give him a little puff at the end. Little puff now, Ray. That's perfect. And now we're going to need another 8-0 balloon here. Little puff, Ray. Fantastic. Great. All right. So now we're going to balloon with an 80035 balloon, and we're done. Popliteal, yeah, we'll take a look. We'll take a look at it. I don't know what it is. Just shockwave, maybe. We'll see. So, ladies, another pain is coming now.
Nominal 6.
Okay. No.
So, no? You can only go to.
Yeah, let's go up here. A little bit of pain coming up. Ten, 12, 14, 16, 18, 20, 22. Keep going. Keep going. It's okay. The roaches will deal with it. Okay. That's good. You expanded it. Down. Good. Okay, so we expanded that. Right there. Go up there. This is fine. I'm okay with this. Yeah. I'd go at least till 12. Okay, down. Good. It's completely expanded.
I need a shockwave. 5-volt shockwave.
Okay, DSA? That's a little intramittal hematoma. I'm fine with that. I can't.
Wow.
This is where the money shot is. Let's see, there's something going on here. I can already tell. I think leave it. No, definitely take care of it. So we're going to do a shockwave. I don't think you need a shockwave, just DCB or put a short stent.
Knowing what happened, knowing what happened, he doesn't want it.
I think we'll do a nice little. Is that really calcium? Go off roadmap here. No, let's see. I just want to see if there's calcium. All right, let's give me a coronary shot, Dave, Ray. Coronary. Are we in coronary?
Yeah.
Okay. Don't inject till I tell you.
Coronary.
Ready? Yes, inject. Yeah. Yeah, I think we need shockwave. All right, let's put an 014 wire. Why don't you go do your left main? 014 wire down, and then we'll do a shock. Oh, it's not even there. So 014 wire and shockwave. So David, With that, we'll sign off. We're going to shockwave. Obviously, we'll do runoffs to the foot. I want to let our AV team go. I want to thank everybody for staying with us. We're going to do a shockwave DCB of this one, and then we're going to be done. So we'll see you guys in January. Thank you again.
Thank you, Dr. Krishan.
Take care. Thank you.
Great case. Great case.
Thank you. 0 and 4 wire in the shockwave.